neuro monitoring during spine surgery. I'm going to give you some scenario in the form of case presentation so that these will be acting as examples, and that will lead to understand some of these basic principles of IOM and signal recognitions and immediate interpretation of the signals and pitfall. So now question is, why is intraoperative monitoring? So this is done to provide a physiologic look or functional pathway from the brain to brainstem, spinal cord, cranial nerves and nerve roots. And during neurospinal procedures, IOM prevents the possible iatrogenic injury to the nervous system. This is the picture I want to show you. I showed it before also, that before making any plan, we'll have to have our aim and objective and attitude. So we'll have to select what type of surgery you want to do. Is it scoliosis surgery or placement of the pedicular screw or removal of the cord tumors or nerve roots stimulations? So you have to attack every problem with enthusiastic attitude as if your survival depended upon it. Now on the left hand side you can see the anatomy of the spinal column, but the other side the anatomy of the monitoring, intraoperative monitoring. We look for the soft tissue surrounded by the bones. In the spinal canal we have the spinal cord and the nerve roots over there. So our main objective to protect the soft tissue, the vital tissue, the neural tissue. On the left hand side you have got the instrumentations. Mostly you do with the fixation of rods and then disc replacement, but this side we and also the pedicular screw insertions, and the pedicular screw is inserted through the pedicles to the vertebral body, but nearby you have got the nerve roots. So this nerve root function of its and its injury is monitored by having a feedback from the EMG burst from the corresponding segments. So we stimulate the pedicular screw and get the feedback from the muscles. Now here is who, because intraoperative monitoring is a teamwork, and here the surgeon acting as the master or the leader of the orchestra to get feedback from everybody so that he can perform the surgery in a successful way. And what the neurophysiologist doing here in the corner of the room, he is looking at the signals to give immediate feedback to the surgeons what is going on with the neural tissue near to the bone structures. The functional principles of the intraoperative monitoring for the spinal cord surgery is to look after the ascending and descending tracts. So in the ascending tracts, we are looking at the functions by performing the somatosensory evoked potentials and recording potential from the cortex. And the motor, we stimulate the motor cortex and then recorded a free run EMG or stimulated EMG, as well as we also look for the spinal cord or corticospinal tract functions. And as we have got two modalities of test, sensory and motor, why don't you do only one modality of test and look after the functions? That we could not do because there are two distinct pathways and has got two distinct circulations. So if you look after this one, the SEP is looking at the dorsal column. Is looking at the dorsal column, which is supplied by the posterior spinal artery, and this anterolateral column is supplied by the anterospinal artery, and all of them they are coming from the branches of the vertebral arteries. So there are two different circulations. That is why you will have to look after two modalities of test, both SEP and MEPs. Here is a protocol for the SEP and MEPs, and we put electrodes according to the 10-20% EEG system of Jesper. But the only thing is that from the midline array, transverse array of the electrodes, we go 2 centimeter in front and 2 centimeter behind. The electrodes in the blue color, they are the recording electrodes for the somatosensory evoked potential, and these are the electrodes to stimulate the motor cortex. And here it looks like in the operation theater when you put the electrodes. Now we also look after the motor functions of the corticospinal tract and the lower motor functions of these motor nerve to the muscles, and these functions in the upper motor neurons, when you stimulate the motor cortex, we record this wave. We call it the D wave, which is direct activation of the pyramidal tract or pyramidal cells. And then after that you get series of waves called I waves. These are the indirect activation of the pyramidal cells and the corticospinal tract. And then from the muscles we get the compound muscle action potentials. But this is what we do by transcranial stimulations. But for transcranial stimulations, you will also have to look after these important points, the contraindications. If the patient has history of epilepsy, cortical lesions, or raised intercranial pressures, and especially if you have got sleep sessions and the cardiac pacemaker, these are contraindications for the transcranial stimulation. Here is an examples how we do the test. This is a schematic diagram. So you stimulate the cortex, and we have got an anode and cathode. You can give anodal current is better than the cathodal one, but you can reverse this stimulus polarity, as well as you can give alternate stimulations. And when you put your electrodes in the rostral and caudal and rostral part of the operational field in the epidural space and record D waves. And then with the stimulations, you can also you have to record the muscle compound potentials from the different upper and lower limb muscles. So the whole pathway you can monitor. And then for the recording we use some montages. This is not possibly it's not so important for you, but we look for the peripheral response. This side is the SEP for the upper limbs. So this is from the arps point, and then you can see the cortical response, this one, which is the N20. The other side is the P40. So these cortical responses are very important, and one should do also subcortical recording, because these potentials are less affected by the anesthetic agents. So if we look after the potentials and their generators, here are the table is telling you the position of the electrodes and the generators and their latencies, timing. But for the neurosurgeons and spinal surgeons, if they can remember only few potentials, I'm very happy. The arps potential, which is the cervical, coming from the cervical plexus, and the cortical potentials coming from the sensory cortex for the upper limb. And the lower limbs, they should remember only P40, what is going on with this one. And the warning criteria, there is absolute warning criteria, 50% drop of amplitude and 10% latency prolongations, 50-10. And there are so many centers, they are also using presence and absence of the potentials as a criteria. But other empirical criteria, such as if you have got change in the potential, you should also see, is the change reproducible? Or if there is a transient loss of SEP, we should not jump to the surgeon and say, oh, there is a loss of SEP. You just give some time and see whether it is there. and this transient loss is give you a good recovery. But these potentials are more reliable because they are not affected by the anesthetic agents, as I have told you before. If you want to look after the signals, this is the duty of, I feel all of us in the operation theater should have a look what is going on. So this is the peripheral potentials, and gradually it goes up, and you can see all the potentials we make 2 times to give you the reproducibility of the potentials, indicating that these are really potentials, not an artifact. But what happened here? All the potential, they lose their morphology, they are longer in latency and low in amplitude. This is the time when the whole team, the anesthesiologist, the neurophysiologist, and the surgeons, we should jump over there and try to recover the potentials. So this is very easy to recognize potentials and make immediate reactions. So this is some of the scoliosis case I have, and you have got the motor evoked potential and sensory evoked potentials, and you follow them, and throughout the whole surgery it goes the same way without any change in their morphology or latency. So we make this surgery. This is another case, normal case. You can see the MEPs and SEPs. You can display the MEPs over here. This is the lower limb SEP. This is the P40, and this is the N20, as I have told you before. And then these are the potentials. You can put it in this way. And you can put the potentials in the cascade form so that any time domain changes, you can see immediately and you can open them. So this is another way of displaying your data. Here also the muscle potentials you can display, so you can see the latencies, either a change or either a change in the amplitude. So this is also another time domain way of looking at the potentials. But in the theater, there are other factors are also very important: change of positioning and the hemodynamic modulations, anesthetic agents, and other electromagnetic interference. You want me to go quickly? Okay, this is SEP loss due to prone positions, and then here is effect of hypoxia. The MEP disappears, and when we do the EEG, you can see that the EEG shows burst suppression pattern, telling you that there is hypoxic brain insult, and when the EEG came back, and you can see the MEPs came back. Here is one of my patients I did here in this hospital with Dr. Siddiqui. The potentials were quite good, and then suddenly disappeared. And then we went and we found that the blood pressure drops down to 46 systolic, diastolic, not obtainable. On the correction, it came back. So when there is a change in EP, you have to look after, is it a non-surgical etiology or surgical? Surgical, these are the causes, and these are these things. Here is your examples to see the halogenated agents. These are the peripheral potentials. They are quite good, but centrally as these cortical potentials with the anesthetic agents, they disappeared. And here also cortical potential. But the subcortical potential shows little changes. Here is examples where the excessive destructions causes the disappearance of the potentials. When you do undo it, it came back. And here is the another important thing is that when you do the stimulation to the nerve peripherally, you get the peripheral potentials. The cortical is quite good, and these peripheral potentials, they become smaller and disappear. They also disappear, telling you that there is a stimulation failure. When you adjust the strength of stimulation, they came back. So you have to look after yourself before going to the surgeon and asking him to stop. And nowadays there are different modalities of tests done, and different types of anesthetic agents we should use. As for example, if you use SEP MEP, it's better to have the TIVA with propofol infusion with opioid. And if you do the only free run EMG, do inhalation agent or intravenous, but do not use neuromuscular blocking agent. Here is an examples of Dr. Husam's case. We were with the halogenic agents, and most of the time the potentials were not there. I was waiting for about 3 hours. Then some anesthetist convinced to give me TIVA, and the potential came back. Nothing happened. He did the surgery in 10 minutes. So that is why possibly the neurophysiologist and the anesthesiologist, they are always not in harmony. So that is why possibly the Los Angeles anesthesia friendliness scales is discovered. So we should be friendly with everybody. So with the TIVA, recording condition is good, but if you go for halogenated agents, they are fair to good. But when you go to more than 1.5 Mach, nothing come out. The motor evoked potentials all disappears. And here is an examples of one of my patients. You can see the quite good baseline study, but when at the end of the toward the end of the surgery, all potentials disappeared. So we continue with the sensory. They are there. So we thought that the cortex and the process is all right, and then we went to the anesthesiologist. Initially he denied that he didn't do anything, but later we found that he used muscle relaxant. This is one of my patients. You have to give the little time. Okay. So here we had to do workup test because at this time when the screw was inserted, surgeon felt that the whole the wall of the hole was broken. So we continued the monitoring, and our monitoring was quite good. Only these potentials are the black one is the baseline, the other one is the ongoing. That was a little small size. But we found that the upper limb also small. So the amplitude change is because of the generalized factor, not the surgeon's fault. And then it became like this. And one of the patients I did with Professor Jamjoom here with the ependymoma, and you can see here. And when he did the myotome, this side the sensory potential disappears. So he said it is expected because he has to enter into this cord. And then other things are quite good. And you can see this one. And this is the pedicular screw stimulations, and it is also dangerous. And every segment, if you say that I am in the lumbar L2, then you have to put your electrode in these muscles and then do it. Okay, this is one of my patients I did with Dr. Sibai, and the patient had fourth vertebral body, L4 vertebral body fracture, and we monitored these muscles, and we got warning in the right side, but left side the threshold was quite good. And this is something about the D wave, which I said, and this is my last slide. So when you do the D wave and the MEPs, then you have to look after this warning criteria. You can see your warning should be very strong warning. If the D wave is less than 10%, 30 to 50%, muscle potential is present, no deficit. But if it is like this, transient, but if it is less than 50% and no muscle MEPs, and is permanent deficit. And this is nowadays people are doing, and neurophysiologist can monitor at least 4 or 5 patients at a time from his own office by this remote controlling. And this is the new planet discovered a few days before, and it is about 600 light years from our Earth. Maybe near future, Dr. Hussam will look after will do the operation here, and will monitor from there. Thank you very much.